आ सकता है if the assessment is not clear. So this is posterior canal, horizontal canal and anterior canal. Sir, how you prefer assessments?
I prefer the same setting. First go to the right.
Huh.
Right. Simultaneously rotate him to 90 degrees to the left.
Yeah.
Commonest one. This I have learned first time.
No, because this also you can do, but if you're getting, like you have already got nystagmus and there's a multi-canal involvement, so stop and go. Stop and go, because we don't want a confusion of geotropic, apogeotropic, because if you check on the right, you get it on the left. The same thing will happen if you check the left and then go on the right. So just keep that assessment clear. Yeah, for example, now he is getting this. So this is also the right, not right pillow, but still we can use it. Just below his neck, 30 degree and turn. Like this. Right sided. Sir is suggesting you can go immediately on the left, but sometimes when the patient is severe, you may have an overlapping of the geotropic, apogeotropic. So go step by step. So this was your diagnostic method. Now we will go for the maneuvers. Chalo. Okay. So you want to perform Epley's on him? Yeah. Fine. So you want to go conventional or? Oh, fine. I'll go. So sir is demonstrating. He's helping me today for doing the Epley's maneuver. Yeah. So see how it is done. So you need a mic. Okay.
Madam, we have already seen the videos. Suppose the right side is involved. Posterior canal, we have come to a conclusion that posterior canal is involved, and it is on the right side. And it is a geotropic variant. Big Solpike already given it. Okay, I think I'm audible. First step is, as madam has said, the first two steps are same as Dick Solpike. 45 degree to the right, because right is this thing, if affected side, then I will take him down. Speed is not important. 30 degree below the horizontal plane. Wait for nystagmus to disappear. I would wait at least 15 seconds, maybe 30 seconds after the nystagmus disappears. Then 30 degrees to the another side.
Yeah. Suppose if I am assisting, I am assisting sir, so I will take the position on that side, and then I will
Then
turn.
I will explain him another time. First time already I have explained. आपको अभी लेफ्ट lateral position में जाना है. गर्दन में करूँगा. ठीक है. Neck rotation is kept at 30 degree relative to the body. This is the fourth step.
Towards the
Again nystagmus disappears, vertigo disappears. Then I will ask him to sit, keeping the neck rotated. And finally after maybe 10-20 seconds, we'll ask him to flex his neck. So this final thing, this is a modification. Many people will skip this test. And finally this is the one rotation. I will go for two of these things at the first setting. At least two Epley's in the first setting.
So this is how you perform an Epley's maneuver. Sir has explained it very well. And now, we'll wait. So basically now this is how you do the posterior canal assessment. Now one thing I have shown you is left to be shown is a Simon's maneuver. I think we'll give this table some rest, and we will take it when I just finish with the vestibular rehab. Okay? Because I don't want it to go down. And then Arpana will pay the expenses of the table also. Okay? So the last lecture for the day is the vestibular rehabilitation. My Simmons is left. I will be demonstrating that. No worries. So she can sit down. ये लगेगा खत्म नहीं हुआ एक और बाकी है साइड में कर सकते हो okay now vestibular rehabilitation the very important aspect we want to talk about vestibular rehabilitation. Now vestibular rehabilitation is important because you want the vestibular compensation mechanism to happen. We have already spoken upon the utilization of brain plasticity. Why? Because the brain adapts what you see. What you see was what brain adapts to. And the cognitive processes, because cognition is a part of the rehab processes, which I'll be explaining now in the slides. Sensory input of the signals, how the brain is picking up, how your reflexes are working, that are equally important when it comes to the rehabilitation part, because this is a new normal of that patient. And these things are the checklist. how the strengthening of the muscles, and how is the dedication and motivation of the patients in such cases. Are they motivated enough to do the exercises? Because how much ever you will tell, if they are not understanding, the things will not work. Basic evaluation, screening of the patient. Now, I had a patient who has had a bit of 45-degree angulation, maybe a torticollis that like type which had developed. He never had a congenital torticollis. For assessment, it was difficult because every time he used to move, he used to have vomiting. So what we did some days of physiotherapy, and unless we got it movement, we got it extension we wanted for Epley's, and then we did the physiotherapy. There was always a question, if there is more movement of the neck, how will it happen? Because there are three reflexes: vestibular colic, vestibular spinal, and vestibular ocular reflex. That three reflexes, along with your semicircular canals, works for your balance apparatus from the inner ear perspective. So posture screening, the posture, I am having skyposis, scoliosis, I am having listhesis issue. So that all things will assess, important from the rehab prospect, not from the treatment aspect or for the diagnosis of BPPV. Sensory signals, manual muscle test, gait, cervical screening, I showed you how to do it. How to do the cervical screening test. Vertebral artery screening test. Now, very simple understanding, when you are doing right distal pike, no, you are actually checking the left vertebral artery. Very simple, because either the same thing happens, the right vertebral artery, district when you are checking the left vertebral artery. So if something has to happen, it will be 5 Ds and 3 Ns. 5 Ds will be diplopia, dysarthria, dysphagia, dizziness, drop attack. Finish, matter ends. And nausea, numbness, nystagmus. So 5 Ds and 3 Ns are seen in VBIs. Okay? And tuck test, timed up and go. So this is done in timed up and go test. So in that, the patient, an elderly patient is made to sit on a chair, and at a distance of 3 to 3 meters, they are asked to go walk and come back within the span of 13 seconds. So if they come back now, so that means everything is okay. Their gait is relatively okay. But before that only we do Romberg's and Utterberger, so not that preferred, So it's more preferred in a physiotherapy setup, a timed up and go test. So just an example of how an uncompensated unilateral vestibular dysfunction or a uncompensated BVD is bilateral vestibular dysfunction. The patient will complain of an history of a vestibular event or a vertigo, or an history of nausea, emesis, and an auditory system may or may not be present. Subjectively, the patient will have oxalopsia, it will have balance problem, it will have hallucinations, visual issues. What you need to evaluate? VOR is vestibular ocular reflex, VSR is vestibular spinal reflex. And what are you going to assess? You're going to assess the gaze of the patient. You have to assess the HIT, that is the Hinds examination protocol, head impulse test, and dynamic visual acuity. What you are expecting out of it, there may be an nystagmus or an oxalopsia that the patient may be complaining. In VSR, that is the vestibular spinal reflex, you are doing the clinical test of sensory integration of balance. So basically the Romberg's protocol is what we are going to use, Gans protocol. Okay? Fukuda is a high-stepping Utterberger test, and Gans SOP for the vestibular impairments that can be happen. The treatment protocol will include vestibular rehabilitation therapy, which has adaptation, habituation, substitution, and balance retraining exercises with something known as cognitive movements. So this is Gans SOP. Anyone from the audience? Because I wanted to give rest to Shashi. Any from the PG students there? Anyone? One can come here. Divya, you only come if nobody is coming, then fine. So it's okay. So modified Romberg's. So what is that, So what you have to do is you have to just stand with keeping your eyes closed. Shoes utarwa dena hai because proprioception hai. Divya, you'll be able to remove shoes. Fine. So remove your shoes. Yeah. Okay. So we just ask her. The slides are visible, right? So just ask her, keep your hands by your side and eyes closed. This is your Romberg's. And what you want, eyes closed. So if we are seeing if she is moving aage piche, or she is losing her balance, is there any postural instability coming? What is modified Romberg's? You ask her to keep your hands straight. And आँख बंद ही रखना है, क्योंकि हम ये eyes का vision जो है उसको block कर रहे हैं to have the assessment of the spinal reflex. So we are just assessing the sensory denial कर रहे हैं हम, because eye sensory vision denial कर रहे हैं, so that we assess the vestibular spinal reflex. This is for the balance. Okay. Then we ask her to do Fukuda high stepping. Now open your eyes, heart straight, and start doing high marching. So she will march at the count of eyes closed. 90. Just do it now. 90 ke count pe. So what you will see now, eyes open now. You will see that she may has turned maybe this much, or she may has turned this much. More than 30 degree, shows that side vestibulopathy, that side where she moved. Okay, so this is Gans SOP. People prefer doing tandem, but I am of the impression if they are not able to perform Romberg's and Unterbergen, how will they even do tandem? So this is a difficult. So tandem, many neurologists prefer over all this, but Romberg's, modified Romberg's and Unterbergen should be done for the assessment. Huh. You want to sit or you want to participate in a rehab? Okay, fine. Give her a chair at least till the time. Huh, fine. Okay. So now hybrid approach. Now for the hybrid approach, there are 4 things that you do. One is adaptation, habituation, substitution, and cognition processes. Adaptation exercises are the one which you do with the help of head and eye movements. The only thing that can be challenged is a retinal slippage. So the frequency of the exercises should be reduced and they should patient को बोलना है कि भाई घाई नहीं कर रहा है तो retinal slippage हो जाएगा. So go slow because it is the eye. So if you're not fixing your eye movements, you're not starting with the rehab. You will tell physio, you will do it on the neck, but you're not working on the eyes and the head itself, which is the premium. The entire vertigo investigation are based on the VOR reflexes and the nystagmus. So whenever you want to settle things for the patient, start with the eye and the head movement. And tell the patient that it will take 3 weeks for it to stabilize. So even if you get vertigo, first the patient should be clear of BPPV. And even if they get vertigo post, you are sure that BPPV is not there. Even if it is there, it is okay because it will stabilization will take time. It is not going to happen very fast, but this is going to give long-term results. Okay? Habituation, we make use a bit of spine with the compensatory mechanism from the head, and substitution are mainly done with our physio friends by using of a trampoline or a physio ball and the change in the foam. We basically want to change the surface because we are going to make use of proprioception, which is there in our feet.